thank you for joining us again for this episode of the Combat Medical Innovators podcast. We're very lucky to be joined by Dr. Lana Bijelic, who's the Chief of the Peritoneal Surface Malignancy Unit at Moses Brogi Hospital in the beautiful city of Barcelona. Lana, how are you?
I'm great. Thank you very much for the invitation. It's really a pleasure to be here.
No problem. As we were discussing, I think the last time I saw you, it's the only time I've ever walked into a department that's specifically called Peritoneal Surface Malignancy Unit. That sort of answers my question, but tell me a little bit about what you're working on now.
I am really very lucky as a surgical oncologist who has a very strong and specific interest in peritoneal surface malignancy to be able to work in a unit that is so specialized and highly dedicated to the management of these patients. So that's really what we do. We are a high volume unit that's dedicated to treatment, surgical treatment, but really multidisciplinary treatment of patients who have peritoneal metastasis from a number of different diseases, from a number of different primary tumors. And in our case, that is a mix of colon cancer, ovarian cancer, appendiceal cancer, mesothelioma, and sometimes other rare cancers that can also produce, in some instances, peritoneal metastasis. So our work is mostly clinical, but we have also strong interest in research. So we try to combine those two activities.
You probably do more peritoneal surface, certainly HIPEC treatments in your centre than in the whole of the UK. I don't know if that's a good statistic or a bad statistic, but it's certainly an interesting one.
I think it's a little bit the reality too. So we have known for a while that peritoneal metastasis as a whole, when you look at all of the tumors that can produce them, are not all that rare, but they have been a big challenge in terms of treatment for many years, really with no solutions for many years. So when the door opened for surgical treatment combined with systemic treatment for these patients, a whole new field really opened up in surgical oncology, which is probably the greatest change we have seen in the last 30 years for these patients. UK perhaps is organized a little bit different. It is true that it has fewer centers, but very dedicated to specific diseases. We have a little bit of a different scenario in the sense that we have the opportunity to treat peritoneal metastasis regardless of the tumor of origin. So I guess that is what differentiates our unit a little bit from the units in the UK. In
my training 100 years ago, the little bit of surgical oncology I did, most of the patients you see, even those with relatively low PCIs, would never have reached the surgeon. If they had, somehow we'd open up and look and close immediately again. So there's real progress here, certainly in terms of the work being done. The UK and the rest of Northern Europe are becoming outliers now that they haven't adopted these new and innovative procedures. Where did you get into this from? Talk a little bit about your training and your background. Is anybody born wanting to be a specialist in peritoneal surface malignancies? How did you get here?
I'm not sure anybody's born, but perhaps the newer, younger generations will find their love for this field early on in their training because they'll be able to see it. But I had, I think, a very lucky path in the sense that I did my surgical training in the USA, in Washington, D.C. And it happened to be in the hospital where really the father and the greatest innovator for peritoneal surface malignancy field, Paul Sugarbaker, was working, and he had his team and his unit there. So I came in contact with this work really as a resident, as a senior resident, and it was, I don't know how to say it. It was a very special experience and really a moment of just great impact and change for me, because I saw something that I had never seen before, that was so impactful in its result, in how different it was from the rest of surgery or even surgical oncology that I was exposed to. And it just made a lasting impact, and just it had to be something that I wanted to pursue. So I was very lucky to have this contact really with the person that is just a very, very special figure in this field. So I continued on with the fellowship with Dr. Sugarbaker, and then I stayed on really as part of the team for quite a number of years. And then from there I moved to start a new program in the USA, not far from Washington, D.C., where I stayed for about 5 years. And then the call came from Europe, which is kind of my hometown. I'm originally from Croatia. So going back to Europe at some point in my life was definitely also in the cards, I guess, and a secret wish. So I think I was lucky again, you know, I was able to practice what I love to do. And on top of that, in a really very advanced, high volume, already established unit in Barcelona. So that's where I am today.
The opportunity to learn side by side with the surgeon who invented the procedure, and I think probably went through some of the pathway of this, originally being seen at the lunatic end of innovation and then being accepted as the gold standard procedure. It must be wonderful to have been on the same path as that. What do you see in your general practice in the centre in Barcelona? Is it mostly ovarian? Is it mostly colon, stomach, or do you see a bit of everything?
We do have a mix of patients with different profiles, different tumors, but as far as frequency, I think something that is relatively special and unique about this unit is that we do have a high proportion of patients with colon cancer that we treat. And that is, on one hand, not surprising, because colon cancer is the most frequent of all of these different kinds of cancers that can cause peritoneal surface, peritoneal metastases. And even though only about 15% of colon cancer patients will have this manifestation of disease, globally, the total number of patients who are diagnosed with colon cancer is far higher than, for example, appendix cancer or gastric cancer. So that translates to a large number of patients that may need this kind of intervention. So that is, on one hand, the explanation of why we see so many patients with colon cancer. The other one is really the fact that you need a very close collaboration and communication between surgeons and medical oncologists for colon cancer to really be recognized as a situation where this kind of surgery can be of help. And that has been something that's been built here over the years slowly, but it has reached a very high and mutually, beneficial level of collaboration where the medical oncologists, do their best and do their part with systemic treatment, which is essential for colon cancer. And we are able to then select the right patients to offer them surgery, and also to great benefit. So I think that's something that's quite unique about our unit, and that we really enjoy that we have reached this phase.
Talk to me a little bit about patient choice within that. You mentioned patient choice. I had the, let's go with pleasure, of being in the room in France when the Prodigy 7 trial was announced, which, if I take my vague recollection of it, said that this doesn't work, especially not in colon, and we shouldn't be doing it. And I was stood in a room with 10 other people who were making a living from selling machines that helped with this. We considered throwing them all in the Seine. How has that developed on post-Prodigy 7? How has that influenced your patient choice?
Well, I think anytime we advanced in the scientific knowledge, that has to change our approach to some extent. Of course, we learn from every study, whether it's a clinical trial like the Prodigy 7, which was really the first big randomized clinical trial for surgical treatment of PSM for colon cancer, but it's the first and the only one of this profile. So it cannot answer all the questions we have about this at the same time, but it certainly has advanced our knowledge, and it has informed of what we do. But it hasn't closed the door, of course, as it shouldn't, in terms of eliminating, like you said, HIPEC. So just to summarize very briefly, PRODIGE 7 was a trial that basically evaluated the impact of complete surgery, cytoreductive surgery on peritoneal metastasis of colon cancer with or without HIPEC to see how much HIPEC could add. And of course, HIPEC is not one thing. HIPEC is really a technique that can be used with different chemotherapy drugs for different duration, at different temperature. It has many factors, many variables that can be played with, and all of them probably do have an effect. So it chose one HIPEC treatment, which was a short treatment of 30 minutes with oxaliplatin. And it turns out that this particular HIPEC for colon cancer patients does not seem to add much more to what surgery can do. That being said, the surgery itself was very impactful. So at the least, we learned that and we confirmed that. And then we sort of started to really focus on the details of this HIPEC. And it turns out that perhaps studying it in more detail, it shouldn't even surprise us so much that this particular HIPEC was not as effective as we wanted to. But that doesn't lead us to the immediate conclusion that different types of HIPECs also don't work in colon cancer. So that's really where we are right now. We are at the phase of, perhaps selecting some patients with colon cancer for surgery only. But then in the majority of patients, we do add HIPEC. We do add a different HIPEC that is, contains different drugs for different duration, and trying to learn from that. So even though building a new prospective clinical trial with a different kind of HIPEC is going to take time, and actually there is one currently ongoing in Spain, and we are participating in it. And for those patients who are not willing to join the trial or don't meet the criteria to enter the trial, we are collecting data and analyzing it to see if we get some sort of signal of whether a different kind of HIPEC can be beneficial and in what way.
It's interesting to see. We do a similar technique with urology surgeons in your centre and in many others across Spain and the world, because they face the same problem of a potentially incomplete surgical resection of the tumour in a difficult space that they feel they should add chemotherapy treatments to it. To heat it's a very natural option, but they only use one drug. In urology, you have primary treatment with one drug, and then you have radical surgery to remove everything. It's excellent to see that there's much more debate in the surgical oncology world about what drugs should be used. Now, I'm from an orthopaedics background, so I can't discuss pharmacology in any way without bleeding from my ears due to the intellectual rigour required. But as the medical oncologists mix up their different magic potions, we hope that we'll find the right one and it will continue. Let's look at the other side of patient choice. Depending upon the degree of spread and the peritoneal carcinomatosis index, what do you do? What techniques do you have available in this innovative unit?
Yes, so that's an aspect that we have certainly over the years evolved a tremendous amount in terms of understanding which are the prognostic factors that really dictate outcomes of peritoneal metastasis, and whether surgical treatment is appropriate, whether it can give us satisfactory results. But that is not one size fits all. That is very dependent on the biology of the tumor, certainly by tumor origin. So it's not the same, the PCI, which is a measure of tumor volume in the peritoneum, that we would consider acceptable for surgery. It's very different for a pseudomyxoma, for example, which is a low-grade appendiceal tumor compared to a colon cancer, compared to a gastric cancer. So that is very, very variable. And it's not the only factor that we take into consideration. There are other factors as well. So here, to me, the main message that I think still we sometimes struggle to sort of get across is that you really need an expert in this field to determine all those factors and decide whether this kind of treatment could be offered or no. And I feel like that sometimes those decisions perhaps are taken without consulting with an expert center, which is a loss, because I'm quite sure there's a number of patients that perhaps are not evaluated at the right time point by the right people to really make sure that everything that we have nowadays at our disposal is offered to them. And this is speaking mostly about CRS and HIPEC, which is sort of the main surgical treatment, and also the one which generally is applied to patients with an intention to eliminate or cure the disease, or at least achieve a long-term control. There are other tools that are sort of emerging. For example, PPAC is one of them that has slightly different goals, and different patients are selected for it. But it's a field that it's evolving. It's evolving both on the surgical side, and certainly it's evolving in terms of understanding all of the complex biology of peritoneal metastases. For example, there's a whole field of immune therapy that has opened up on the systemic treatment side that we haven't quite translated on the local regional side yet, because there's so much we need to understand about the immune environment of the peritoneum to be able to apply that.
Talk to me a bit about where we are with the PD-1, PD-L1s, and that side of it. Somebody very clever sat in the offices of Pfizer somewhere must have invented blizarbumab or something else that's now going to be the wonder drug for peritoneal spread. Where are we in that immunopharmaceutical space with innovation?
Well, I think we are still in the early phases, but there's definitely a lot of interest, and there's definitely a lot of activity. But early phases in the sense that there's still so much unknown about what makes the peritoneal environment different than the rest of the body, the systemic environment from the immune standpoint. And some of the studies that are out there or that are coming out suggest that it's actually quite different. So there may be aspects of the peritoneal response to metastasis that is really unfavorable in terms of the natural ability of the immune system to fight metastasis. So there's a lot more to learn, and certainly what you mentioned, sort of a peritoneal specific drug, would be an incredible advancement. I don't know of one existing yet, but that would certainly be a line of innovation that we all want to pursue.
I've written it down here. I think I said blizarbumab. That'll be the one. Sounds good. Sounds right to me, doesn't it? Sounds like one of those drugs. That's for the heavier end of the disease load. Let's take it to the other side. What should we be doing in earlier stages? We have a trial ongoing in Italy where every patient who has a colectomy, where there's positive cytology in the peritoneal fluid, gets an additional cytoreductive treatment, whether it's HIPEC or PIPAC or something else. Is that where we're going? Or is that unnecessary pressure from the terrible commercial bastards like me to use the product in every procedure? What about early cases, early disease?
Yeah, so that is really a very interesting question for two sort of simple reasons, if you want to simplify things. On one hand, we know that the more tumor burden in the peritoneum exists, the worse our results are. So it seems logical to try and catch this process as early as possible, including treating patients that haven't yet manifested it clearly, but we know they are at high risk. So that's really the logic of trying to put this treatment earlier in the process of how it evolves, how it comes to be. And second, because of course the morbidity, the difficulty on the patient when we have to treat already established peritoneal metastases with this really big traumatic surgery versus if we could apply some aspect of the treatment, like for example the HIPEC, which is really much less morbid in itself compared to the surgical procedure. Earlier, it would cause much less harm, or it would cause less difficulty in recovering. So that's the logic of why we would like to prevent as many peritoneal metastases as we would like to treat. The rationale is there. The question now is finding proof and the high level of proof that that works and that it works at an acceptable level of risk. And we have had some interesting results lately. On one hand, there have been a couple of trials that didn't prove this very clearly. And perhaps, again, the problem was the type of HIPEC that was chosen, the same one as in PRODIGE 7. Mm-hmm. But very recently, actually, a trial has shown some positive results for colon cancer in terms of decreasing the chance of peritoneal metastasis happening for patients who had a high-risk colon cancer, early stage, but larger tumors and higher risk situation in terms of preventing peritoneal metastasis. So I think that's a very still open area for research. We know of cancers that have an even higher risk of developing peritoneal involvement, for example, gastric cancer. So prevention in gastric cancer certainly would be very, very interesting because of that, because the risk of developing peritoneal metastasis is high. And once they develop, they are really, really difficult to treat. And our results with CRS and HIPEC for gastric cancer are not nearly as good as they are for colon cancer.
We have the same study ongoing in gastric. It's the GIRTH study for gastric and the CHECK study for colon. It's very interesting to see whether early stage intervention is doing too much or whether it's doing the right thing. You spoke about studies in there. What's your research and what are you doing in particular areas of interest in research at the moment? Which trials? What exciting things are you doing on that side?
Well, we're excited even when we do small advances. You cannot expect to advance in this field by giant leaps. But so on one hand, we're participating in this multi-institutional clinical trial, which I think is going to give us some important answers.
This is the HIPEC-T4 study?
No, HIPEC-T4 is already completed. This is and it turned out positive. This is the one I was mentioning. It was really more tiered towards prevention. This one is called Jacob MMC, so it's basically a similar study to PRODIGE 7 in its design, but it's looking at a HIPEC that is longer in duration, 90 minutes, and uses mitomycin C as the main drug, with an aim to see if we get a better level of peritoneal control. So that's an ongoing trial that we participate in. And then we have a number of projects that are within our institution that really span from preclinical to post-operative care. So on the preclinical side, we have just started and applied for funding for really a detailed molecular analysis of colon cancer peritoneal metastasis in terms of understanding whether the key biological variables that define these metastases and differentiate them from other types of metastases, like, for example, liver metastases of colon cancer, which are quite a bit more common, and also between different patients, because we know that the pattern of failure, for example, after treatment with CRS and HIPEC for colon cancer is quite interesting. There are patients who will develop peritoneal disease again, and there are others that will not. They will have liver metastasis, for example, in the future. So they must have some sort of different molecular profile that we need to understand better to know what additional treatment they might be beneficial to them. And then in terms of clinical trials, we're very interested in optimizing the post-operative care and recovery after these big surgeries. So we know that ERAS principles, and ERAS stands for Enhanced Recovery After Surgery, have been applied to a number of different surgeries with great results and really have become standard of care. Starting with laparoscopic surgery, for example, and moving on to more complex side of things. And CRS and HIPEC is on the other extreme in terms of complexity of surgery, but we also know that there's great variability. Not all cases of CRS, HIPEC are the same. So we have developed really a specific pathway for ERAS for these patients that is tiered, that it has sort of 3 sub-pathways that are aimed at giving a different pace of recovery to patients based on the complexity of surgery. So we have been applying this for the last year and have analyzed results, and we are hoping to present it at the next big Congress of peritoneal metastasis, which will be held in Venice, because I think we have learned some interesting things that could help other units optimize in management.
It'll be interesting to see what's presented at PSOGI, because that's a meeting that hasn't happened for a few years. Was it 4 years ago it was supposed to be in China? People seemed somewhat reticent to travel to China at that stage. I can't remember why.
Who knows why?
It'll be nice to be in Venice. I only say it'll be nice to be in Venice because I've paid for the hotels with somebody else's money. But it'll be nice to be on the Lido in November and to see what innovation is coming out from the clinicians, the scientists, and dare I say industry, and see what it looks like. Let's move on to that then, because we spoke a little bit there about personalised treatment, whether through the molecular nature of the metastasis in surgery or chemotherapy, and also through the ERAS process in recovery. Is that how it's going? I'll phrase the question more broadly. I'll throw you the keys to the DeLorean from Back to the Future. You arrive in your lovely centre in Barcelona in 30 years' time. What are you doing? What are the surgeons doing? Are there any surgeons there? What does it look like in the next generation?
Yeah, wow, that's a very, very hard question. In 30 years sounds, it's a long time, but in fighting cancer, I'm afraid that we have a big enemy there. So we don't advance as quickly as we would like to. So I think we will still have surgeons. We are not going to be able to eliminate cancer, and surgery still is a very, very powerful tool in fighting cancer, even metastatic cancer. So that's one big lesson that we have learned over the years, and certainly the evolution of CRS and HIPEC has been a big factor in understanding that. But the idea is I think getting to be as smart as cancer is, in terms of understanding all the different subtypes. I think the future will be perhaps not naming the cancer based on the organ where it started, which is what we mainly still do and how we treat it, but really giving it a name or a profile that's going to be less linked to the organ and much more linked to its molecular and genetic makeup. I think that's going to be a major innovation that is already happening, certainly in medical oncology, in surgery less, but it's starting to impact us. The story of immune therapy is I think, also sort of more at the beginning, and it's going to be a big evolution there. And the surgeon will more and more be integrated into this multidisciplinary team that works together, and where each component of it really is kind of like a puzzle, perfectly integrated with the other aspect. It's not so sequential. Perhaps it's going to be a lot more of combined treatments before surgery, after surgery, then perhaps surgery again. We're learning so much about, how to make treatments less morbid for the patients, but also able to be given in a way that turns this disease into a more manageable, more chronic condition.
Yeah, it's good to hear as a former surgeon there's still jobs out there for those of us with cold steel in our hands. It's known in any surgical oncology area, but perhaps even more so in peritoneal surface disease, that the closer you get to T0 in the traditional fashion, then that's better. Whether we have new and exciting chemotherapies, administrations, immunologies, voodoo, or whatever else we come up with, there's still a role for the good and accurate surgeon. I'm glad to hear that. We've covered quite a broad range from the very start of the disease to the end of the disease. We're working on a number of early intervention products through Combat Medical. We have a intraluminal system to look at, because if you're removing a tumour from the lumen, are you removing it 100%, or would it benefit perhaps from some local regional treatment? Then in the gynae space, in the ovarian cancer space, multiple treatments. We're working with your friend and mentor, Dr Sugarbaker, on... Then in the gynae space and the ovarian cancer space, multiple treatments. We're working with your friend and mentor, Dr Sugarbaker, on NIPEC So that's always something that interests me. In our urology world, the surgeons give 10, 15 treatments. Do you think there's an advantage in doing more in surgical oncology from the chemotherapy point of view? Or are we just busying ourselves and we should take more of a watchful waiting approach?
Well, I think in terms of chemotherapy, really repeating treatments has always been really an integral part of how chemotherapy is used. So I think the HIPEC being used only as a one-off is the exception. And part of it is sort of the difficulties we had in terms of being able to deliver something like HIPEC, and we associated it only with the moment of surgery. But from all the other standpoints, certainly repeated treatments would be a more logical way of applying chemotherapy, local, regional, just the same as systemic. So the smarter we get about how to apply multiple treatments in an acceptable way, I think that's going to be the key of moving HIPEC from a one treatment to multiple treatments. And that, by all other sort of factors, logical way of thinking should increase the efficacy of HIPEC. So I think it's a very intriguing idea, and we certainly know from other studies of normothermic chemotherapy that repeated IP treatments work. We know that from multiple randomized trials in ovarian cancer. So that's an interesting aspect that that we should study more, for sure.
Hopefully we're moving in the right direction to help with that. So a couple of last questions then. I won the lottery in Spain last year, so I've got €1 billion of research grant that I will give away to my favourite centre in Catalonia. What are you going to spend your €1 billion on? New machines, research into biomarkers, innovative trials that compare 15 different chemotherapy regimes?
It's a very intriguing and difficult question. Well, since it's such a great amount of money, I would have to sort of come up with several ideas.
Oh, no, that's cheating.
Certainly, I think we still have quite a bit more of work to do to understand the biology of the disease, to be able to come up with treatments that are more targeted, more personalized, that sort of treat peritoneal metastases specifically. You know, we're still applying basically the same drugs that we have developed for systemic use locally, but perhaps that's not the ideal way. Perhaps we really have to look at what is different about peritoneal metastasis from other types of metastases and try to develop something more specific. And I think there, you know, the lack of the $1 billion, like you said, it's a big factor, because we don't have very good funding for this area of research for peritoneal metastasis, and certainly not for innovations in surgical treatment. So that has been a disadvantage that we are trying to solve by being humble and keep working small, but you know, with passion. But there is a need to study peritoneal metastasis specifically, and not just, you know, metastatic cancer as a whole.
Yeah, I agree. Well, hopefully when we're sat in St Mark's Square sipping on a Negroni at the PSOGI meeting later this year, some of those innovations will have been discussed and will be coming to light. I'm just looking forward to the Negroni flowing, really. Thank you very much for your time today. It really is a pleasure to speak to somebody who's working at at the bleeding edge of innovation in treatment, surgical treatment, as well as medical treatment of this misunderstood and probably historically undertreated but very important group of patients. Dr. Bijelic, thank you very much for your time.
Thank you. It's been a great pleasure.